Good morning. Good morning, one and all. I welcome you all for the another edition of online anesthesia postgraduate teaching program on Zoom platform, sponsored by Acrola and hosted by A1 Logics. Today we have two important topics. It is often asked in theory exams and clinical exams. The first topic is perioperative arrhythmia management by Dr. Guru Sandhya. The second topic is anesthetic management of patients with pacemakers. My good friend of Dr. Ranjan RV from PIMS, and the session will be coordinated by Dr. Shantini. This week, we have only 1 hour of teaching program to spare the time for ISC Tamil Nadu academic events. From next week onwards, we will have 2 hours program. I have one important announcement here. I'll share my screen. So the Institute of Anesthesiology from Madurai Medical College, they are conducting a DREAM 2022. It is a hands-on workshop on anesthesia machine and circuits and vaporizers. So the 9 to 11, there will be didactic lectures that will be followed by 5 stations. The station will deal with workstation circuits, pressure regulators, anesthesia ventilators, and vaporizers and breathing circuits. So it is a good opportunity. So don't miss it. You can make use of it. They allow only 150 participants. Already the registration has crossed 100. So be quick to register and make use of this opportunity. Thank you. Now I hand over the session to my session coordinator, Dr. Shantini Madam. Madam, please.
Very happy morning to one and all. Welcome to online anesthesia. Today we are going to see 2 important topics in cardiovascular system. First one, I invite Dr. Guru Sandhya to speak on perioperative management of arrhythmias. Over to you, Dr. Guru Sandhya.
Sir, am I audible?
Yes.
Good morning, one and all. I am Dr. Guru Sandhya, and I will be discussing on perioperative arrhythmias. So, what is an arrhythmia? An arrhythmia is any abnormality in the conduction or rhythm or rate of the cardiac conduction. It can either be symptomatic or asymptomatic, and it is the most common abnormality in the perioperative period. Dated in IJA 2007, they have documented an incidence of about 89% with continuous monitoring, and the incidence is so high in the perioperative period. The mechanisms involved in arrhythmias are very many. These are the 5 which are included in it. One is re-entry, for which the examples are supraventricular tachycardia and ventricular tachycardia. Any injury to cardiac tissues or automaticity, ectopic foci, and mutation in the ion channels can all be a cause for arrhythmia in the perioperative period. So, if at all an arrhythmia occurs, why should you treat that arrhythmias? These arrhythmias are actually in the perioperative period capable of producing a hemodynamic instability, which can affect the perioperative outcome and can lead to increased perioperative morbidity and mortality, which can lead to increase in ICU stay and hospital admissions. So in the perioperative period, it is very important to identify and treat the cause and the arrhythmia for a better perioperative outcome. So the causes in the perioperative period includes patient factors, which may include the patient may be a pre-existing cardiac patient, or the patient may be of old age, which may predispose him to multiple atrial arrhythmias, or it can be procedure related like intubation, extubation, central venous catheter, or a laparoscopic surgery, and so on. Any pre-existing pathology in the patient, may it be cardiac or fever or sepsis or hypothyroidism or hyperthyroidism, can predispose a patient to have a perioperative arrhythmia. The agents which we use in the perioperative period, like dexmed and phenylephrine causing bradycardia, glycopyrrolate atropine causing tachycardia, and volatile agents causing junctional rhythm, and halothane potentiating the arrhythmogenicity when used along with adrenaline, are all examples of pharmacological agents triggering perioperative arrhythmia. In the perioperative arrhythmias, it is broadly classified into bradyarrhythmias and tachyarrhythmias. Bradyarrhythmia side, there is sinus bradycardia and AV block, and junctional rhythm and bundle branch block. In the tachycardia side, there is a narrow complex and a wide complex rhythm with pulse or without pulse, and pulseless VT and VF. So in bradyarrhythmias, sinus bradycardia, junctional escape rhythm, where the trigger is not from the sinus node, but from the AV node. It can be a junctional rhythm wherein the rate extends from 40 to 60, or accelerated junctional rhythm where the rate can be 60 to 100 per minute. In AV block, it can occur in the perioperative period because of an intrinsic cardiac disease or perioperative myocardial ischemia or any electrolyte abnormalities or increase in vagal tone. In first degree AV block, there is a fixed prolonged conduction defect from the atria to the ventricles. In second degree AV block, it is of two types, type 1 and type 2. In type 1, there is a progressive prolongation of PR interval followed by a dropped beat. In type 2, there is non-coherent drop from a pre-wave conductor to a ventricle. In third degree AV block, atria contract separately and ventricle contract separately. There is no coherency between the atrium and the ventricles. In the bundle branch block, the right bundle branch block can be as a physiology when we are inserting a pulmonary artery catheter. And these bundle branch block in the perioperative period, usually in the left bundle branch block, usually signify a myocardial ischemia or significant myocardial damage, and it must be sought with an expert consultation as well. So sinus bradycardia is a heart rate less than 60 per minute, never occurring as an isolated variable, and integrated approach is necessary. So perioperative causes for bradycardia are Cushing's reflex, as one can see in an increased intracranial pressure and bradycardia. Oculocardiac reflex, as traction on the extraocular muscles can lead to bradycardia. High spinal blockade because of blockade in the cardiac fibers. Local anesthetic systemic toxicity. Interscalene block and Bechol-Jolisch reflex, when some procedure is done in the interscalene block in a beach chair position, it can precipitate a profound hypotension and bradycardia in the form of Bechol-Jolisch reflex, and that should be kept in mind. And high intrathoracic pressure and any myocardial ischemia in the perioperative period can present as a bundle branch block. Hypothermia, hypoxia, especially hypoxia in a neonate, or an endotracheal intubation without an anticholinergic agent in a neonate can precipitate a bradycardia. And electrolyte abnormalities like hypokalemia and hyperkalemia can lead to perioperative bradyarrhythmias. From here on, we will see each and every of this rhythm in an example basis. So this is a 58-year-old male posted for laparoscopic cholecystectomy. Upon infusion of carbon dioxide, he developed this rhythm. So each P wave is followed by a QRS complex. So it's a sinus bradycardia because the rate is somewhere around 55. So how do you treat this? You treat the cause. You ask the surgeon to deflate the abdomen if the bradycardia is like still prolonging and becoming less than 40 or so. Deflating the abdomen would treat the cause because it is because of an intense peritoneal stretch from a vagal stimulus. So if at all it doesn't treat, then treat it with atropine. If the same bradycardia has occurred in case of a spinal anesthesia, say the pulse rate is around 50 per minute and the BP is around 90/50. So it is better to treat with atropine or ephedrine 6 milligram bolus, depending upon the clinical situation. If the patient is on beta blocker, any heart rate less than 50 is taken as a bradycardia. Any heart rate less than 40 is not well tolerated, or because the cardiac output will not be enough to meet the demands even in a normal healthy adult male. So any bradycardia less than 40 it is imperative to treat. So this is another such example. He's a 44-year-old CAD patient going on for a bowel resection, developed this rhythm. As you can see, the P waves are independent and the QRS complex is independent. This is a complete heart block which has developed in the perioperative period. Patient being a CAD might have triggered a perioperative MI. That may be a cause for complete heart block. The treatment for this would be a transcutaneous pacing or transvenous pacing. Second example is another patient with multiple comorbidities with an obstructive uropathy. As you can see here, one P wave is conducted, the other P wave is not. One P wave is conducted, the other P wave is not. But the PR interval is normal. So this is a second degree type 2 AV block. Provided he is hemodynamically stable, we have to actually put him on transvenous pacing and then treat. Since it's an obstructive uropathy, hyperkalemia can still be a cause, and hyperkalemia has to start for and to be treated in the perioperative period. So treat the cause and treat the arrhythmias and then improve the perioperative care. This is another case scenario. He's a 78-year-old male. Upon reversing from a normal uneventful general anesthesia, developed this rhythm. So here there is no P wave, but but the QRS complex is normal. So this is the junctional rhythm with the bradycardia type, not an accelerated rhythm, but it's a junctional rhythm. So treatment would be normally this rhythm developing in case of any volatile agents being given, usually revert to normal. But following neostigmine, it is better to administer atropine in the perioperative period to improve the rhythm to a sinus rhythm. So any bradycardia or bradyarrhythmia in the perioperative period, you see and recognize that there is a bradyarrhythmia. You check for the pulse. If there is no pulse, then it is a PEA and start CPR immediately. If there is pulse, then give atropine. So treatment in the perioperative period for bradyarrhythmias include glycopyrrolate, ephedrine 6 mg IV bolus when it is a spinal anesthesia induced one. Atropine 0.5 mg is an ACLS guided dosage, but 0.6 is what is available with us, and you can use it very well. And if the bradycardia is not responding to atropine, you can still use isoprenaline 0.02 to 0.04 milligrams bolus and 5 mics per minute infusion. Adrenaline and dopamine are the one which are advised in the ACLS guidelines for perioperative bradycardia. Adrenaline at a dose of 2 to 10 mics per minute and dopamine at a dose of 5 to 20 micrograms per kg per minute, titrated to the patient's response. So transcutaneous pacing is useful when there is a type 2 second degree AV block and a complete AV block for improving the cardiac output and the hypotension which would concomitantly occur. So transcutaneous pacing involves attaching the pacing from the pacing patch from the defibrillator. It can be either an anterior approach or an anteroposterior approach. Both have shown efficacy, and you have to set the defibrillator to a pacer mode. You have to increase the pacer output from 60 milliamperes until capture. Say if the patient is capturing at 70 milliamperes, the patient is taking up the pacer spikes only at 70 milliamperes. Then you set the pacer output at 80 milliamperes and then set the pacing rate and the rhythm. You have to confirm capture by tracing the pacer spikes in the ECG and then the improved perioperative outcome. So coming on to perioperative tachycardia. In perioperative tachycardia, you've got a narrow complex and a wide complex rhythm. See, this narrow complex rhythm can be regular or irregular. In regular, see for the presence of P wave. If the P wave is present, then it is sinus tachycardia. If the P wave is absent, then it is an SVT or AV nodal reentrant tachycardia or AV reentrant tachycardia. If the narrow complex rhythm is irregular, then again check for the presence of P waves. If the P wave is present, then it's an atrial flutter. You will see the flutter waves in the ECG. And also when the morphology of the P waves are more than 3 or like the P wave keeps varying in morphology, then it's a multifocal atrial tachycardia. If the P wave is absent in an irregular rhythm, it means an AF. So AF is a narrow complex irregular tachyarrhythmia, and SVT is a narrow complex regular tachyarrhythmia without a P wave. In wide complex tachyarrhythmia, it can be regular or irregular. In case of regular, it can be VT or SVT with aberrancy. It is actually very difficult to differentiate between these two, and treatment would involve depending upon the perioperative setting. In case of irregular, it becomes VT or VF. So the wide complex can be VT or SVT with an aberrancy. The VT can be monomorphic or polymorphic. So any narrow complex tachycardia, first of all, appreciate it's a sinus tachycardia or an atrial tachyarrhythmia which has occurred, and check for the pulse. Always, whenever a tachyarrhythmia or bradyarrhythmia occurs, you check for the pulse and the blood pressure. If there is no pulse, it's a pulse PEA, start CPR. If there is hypotension or impending arrest, you do an electrical cardioversion. If the BP is okay or in a hypertensive side, the inadequate depth or so many other factors can be a cause for the narrow complex tachycardia, and you treat them accordingly. So narrow complex tachycardia, the first one is sinus tachycardia. There are any number of factors in the perioperative period which can lead to a sinus tachycardia. One among them is pain and inadequate depth of anesthesia, which we see it very commonly in our routine practice. Usually it is accompanied by hypertension. So pain can be treated with a shot of opioids, and inadequate depth, you deepen with either an intravenous agent which you are using or an inhalation agent which you are using that would settle the tachycardia which has occurred because of these two. The patient can be a febrile patient or a hyperthyroid patient who is uncontrolled. So the patient factor is also very important, which can lead to sinus tachycardia. Giving a shot of paracetamol would decrease the temperature and decrease the heart rate in such patients. It can be procedure related, as in a laparoscopic surgery, increasing the sympathetic surge, intubation, which can increase the heart rate and the BP. So deepening the plane is the key for intubation, and extubation stress response can be prevented by giving Xylocard, and there are so many manuals which are available to prevent the extubation response. Any orthopedic patient who is posted for a limb or a femur fracture, upon reduction, developing a sinus tachycardia with hypotension and decrease in end-tidal carbon dioxide, circulatory embolus can be a cause, and that has to be treated, and only then the sinus tachycardia will revert. Then coming on to hypovolemia. This usually presents as tachycardia and hypotension. So that also has to be kept in mind. Any patient who is dehydrated or in the perioperative period itself has to be adequately hydrated. It is common practice that the patient somewhere is kept nil per oral throughout the night. So hypovolemia can be a cause, and that has to be treated. Ongoing surgical loss, which has led to anemia, can lead to a physiological increase in heart rate to compensate. So anemia we treat it with PRBC. In the perioperative period, given that the antibiotics given in the theater, then anaphylaxis is a potential cause of sinus tachycardia with hypotension and bronchospasm that always has to be kept in the differential diagnosis when dealing with sinus tachycardia and hypotension with bronchospasm. So this is about sinus tachycardia. So this is a case scenario wherein a 45-year-old gentleman who is a known CAD undergoing a FEMPOP bypass, complaining of palpitations, has a stable rhythm. So this is, as you can see, the QRS complex is narrow and it is regular, but there are no P waves. So there are no P waves. So this is a supraventricular tachycardia. The treatment is, since the patient is hemodynamically stable, you can give an adenosine of 6 mg IV bolus. Initially, you can start with the vagal maneuver. If the carotid sinus massage is effective, then that is enough. If the carotid sinus massage is not effective, you can give adenosine 6 mg IV bolus. If it is not responding, you can go to 12. If an adenosine is not available, you can also see for esmolol if it is available and give a bolus dose and treat the supraventricular tachyarrhythmia. If at all this patient was hemodynamically unstable, then we would have actually treated them with the synchronized cardioversion of 50 joules to 100 joules. If the patient has no pulse, then it becomes a pulseless electrical activity and you go for CPR. So any irregular narrow complex tachycardia, as we have seen, it becomes a atrial fibrillation when there is no P wave. So the treatment depends upon whether the patient is hemodynamically stable or unstable, whether you are aiming for rate control or rhythm control. You achieve for rhythm control when the AF is acute onset or when there is no pre-existing cardiac illness or only the age factor has triggered. So that time you attempt a rhythm control. If the patient has got a chronic AF, in the intraoperative period, he is developing an AF with fast ventricular rhythm. That time you achieve for a rate control rather than a rhythm control. So what is the precipitating factor? If it's pain or sympathetic stimulus, fever or hypoxia, which is stimulated, and that also has to be kept in mind. Any perioperative AF, it is imperative that we refer the patient to the cardiologist to start them on anticoagulation, because if the structural heart is not normal or if the AF is persistent, then it is actually better to start off the patient with an anticoagulation. So this is a 70-year-old male patient who was posted for a pelvic abscess drainage followed by a colostomy. He had in the echo severe RA and severe PAH with an RA and RV dilatation. The case was done under GA without any event. Post extubation, he was complaining of mild pain and then he developed this rhythm. So this rhythm, as you can see, it's an irregular rhythm. It's obvious, isn't it? And there is no P wave which is following a QRS complex, and this is a coarse P waves which is seen. So that's a coarse AF which he has developed because of the underlying severe PAH which he has got in the preoperative period itself. He was hemodynamically stable, so we have given him amiodarone 150 milligrams IV bolus, followed by 1 milligram per minute for 6 hours and 0.5 milligram per minute for 18 hours. If he was hemodynamically unstable, since it's an acute AF, before that the rhythm was normal, we would have attempted a synchronized cardioversion of 120 to 200 joules in the perioperative period. It depends upon, the treatment depends upon whether the patient is hemodynamically stable or unstable. If the patient is unstable, never hesitate to cardiovert. If the patient is stable, treat them with the medicines which is available in the sitting for you, especially amiodarone. You can also aim for rate control if the patient has got a preoperative AF using a beta blocker or a calcium channel blocker in the perioperative period, say metoprolol or esmolol bolus followed by metoprolol, whichever is available, or verapamil and diltiazem in the patient who has a pre-existing AF. So coming on to ventricular arrhythmias, ventricular premature complexes are the one which are usually troublesome and we see so often in the perioperative period. It can be either a pure ventricular premature complex, as in this case, as it is actually accompanied by a QRS complex followed by a compensatory pause, as you can see, because the ventricle has a effective refractory period and there has to be a compensatory pause for adapting to the ventricular premature complex. If it is of same morphology, as you can see here, it is from a single source. If it is of different morphology, then it can be a multifocal VPC, which can occur when there is an ectopic foci in the ventricle as well. So when every other beat is a VPC, it is a ventricular bigeminy. When every third beat is a VPC, it is a ventricular trigeminy. When every fourth beat is a VPC, then it is a ventricular quadrigeminy, and so on. When it is this VPC, when there is more than 3 consecutive VPCs which is occurring, we call them as ventricular tachycardia. When it is not sustained, that is when the 3 VPCs continuously occurring together in a rhythm strip occurs only for less than 30 seconds, it is called non-sustained VT. If it is sustained for more than 30 seconds, then it is called sustained VT. In case of ventricular premature complexes, if this can be because of any electrolyte abnormality or can be a physiological response to a sympathetic stimulation. This usually commonly occurs in pregnancy, also in the perioperative period, which you can see like in the monitor, they'll just have 1 VPC, then take off. This can be because of hypokalemia, hypomagnesemia, or define an intrinsic heart problem also. But if it is concerning, say if it is less than 3 per minute, you need not treat it and it will not be hemodynamically significant. But if you feel it is more than 6 per minute, then you can treat it with lidocaine bolus of 1.5 milligram per kg and treat the cause, whether it is hypokalemia or hypomagnesemia. Give magnesium and then you will treat the ventricular premature complexes which is occurring. Coming on to wide complex tachycardia. Wide complex tachycardia, in case of a ventricular fibrillation, has never an organized contraction, so it will always be pulseless. So it can be treated only with defibrillation. We always have to look for 5H and 4Ts if ventricular fibrillation occurs with the effective CPR. In case of ventricular tachycardia, it can be wide complex tachycardia. It can be either ventricular tachycardia or supraventricular tachycardia with an aberrancy. It is actually very difficult to differentiate these two in the ECG. Provided we can get an expert help, then they can help us. If it's a ventricular tachycardia, it can be monomorphic or polymorphic. In case of monomorphic tachycardia, it can still be a stable VT or an unstable VT. So in case you're going to do a defibrillation for a ventricular fibrillation or an electrical cardioversion for AF with hypotension, you always, if the patient is under spinal anesthesia or if the patient is awake, you always ensure adequate sedation and analgesia and then only perform a cardioversion. You cannot perform a cardioversion on an awake patient because that will scare them more than the arrhythmias. You have to press the synchronize button whenever it is necessary for AF, SVT, or SVT with hypotension, AF with hypotension. You always have to press the synchronize button. In case of defibrillation, you should ensure that you're switching off the synchronize button and then only giving the shock. This is another such example. a 23-year-old female posted for laparoscopic umbilical hernia repair. On giving ondansetron 4 milligrams, she developed this rhythm and he's a hemodynamically stable one. So this is classically a R on T phenomenon, which you can see here. This occurs because the patient might have got a QTC prolongation in the perioperative period, and you might have given a drug which prolongs the QTC interval. So in the ECG, you always have to look for if the patient has got a cardiac disease, or if the patient has intrinsically got a QTC prolongation, any autonomic neuropathy. Always look for the QTC interval and avoid the drugs which can precipitate a QT R on T phenomenon in the perioperative period. One such is what we are commonly and routinely using is ondansetron. We may not know what has caused, but ondansetron might have caused the R on T phenomenon. So the treatment is simple: give magnesium, and it is unstable, shock them. That's all. So magnesium 2 gram IV bolus is what is the treatment of torsitis pointus or polymorphic ventricular tachycardia. And then if it is unstable, you go for CPR. I mean, without pulse, go for CPR. So this we have received from Dr. Praveen from Royal Care to discuss this case. So this is, as you can see in the monitor, I don't know if I'm clear, just wait a second. So this is a regular complex wide complex tachycardia. As you can see, there is no P wave. So it's a wide complex regular tachycardia. So it's a ventricular tachycardia, and it is also monomorphic. And the monitor says it is actually, the patient is actually stable. Now we have to look for if the patient has got any signs of hypotension or shock. This may be from a previous reading as well. So we have to see if the patient has got signs of shock or hypotension or altered mental status. If it is not, it is purely stable VT, then you can treat with the procainamide 20 to 50 milligrams per minute, up to maximum dose of 17 milligram per kg. And I have never personally seen procainamide also. So you can treat it with amiodarone 150 milligrams IV bolus, followed by 1 milligram per kg, 1 milligram per minute infusion for 6 hours, followed by 0.5 milligram per kg infusion for 18 hours. You can also use sotalol, but personally, I have used only amiodarone for such cases. If it is becoming unstable, then you can think of shocking them, and then you actually have to look for the precipitating cause in VT. Say if the patient has got any pre-existing comorbid illness, or what has precipitated this VT, whether it's hyperkalemia or any other electrolyte abnormalities which has precipitated. You have to see the cause, treat the cause, in the interim, treat this arrhythmia also. And any perioperative arrhythmias, you ensure adequate oxygenation. You assess the airway, whether the patient is able to maintain the airway, because if they are becoming unstable, they may become drowsy, irritable, or altered mental status that can lead to airway compromise as well. You see for the ventilatory parameters if the patient is under general anesthesia. See if there is any hypercarbia which is precipitating any sympathetic surge and then triggering the arrhythmias. So we always look for the ventilatory parameters also. Circulatory reassessment is of utmost importance in any perioperative arrhythmias, because if you see, initially the patient may be with an SVT unstable, and later on the patient may progress from SVT with hypotension. Later on the patient may have SVT with no pulse. So reassessing at a frequent period of interval, say 3 minutes, is of utmost importance in a perioperative arrhythmia. You always ensure there is pulse. Then only you can treat the patient, because the treatment entirely differs from stable, unstable, and without pulse. So circulatory reassessment is of utmost importance. You have to recognize the crisis first to treat the crisis. Assess the clinical situation and the potential cause. Without treating this cause, it is of no use to treat the arrhythmia alone. That has to be kept in mind. Ensure adequate oxygenation, because oxygen is life. You treat the cause and treat the arrhythmia, that will lead to improved perioperative care. What I have learned over the years is, what the brain does not know, the eye does not see. This case is once in a lifetime case, which I will never forget in my life, which I have encountered in a postgraduate period. This case is a 75-year-old male who is a known COPD. And he has, actually, I was quite smart enough to take this patient open cholecystectomy under epidural anesthesia. During that, he developed the procedure was uneventful. It was taken by a team and was handed over to me in the IRCU. And I gave an epidural bolus, and the patient had hypotension. Intraoperatively, they had managed the hypotension with a noradrenaline infusion. Postoperatively, I had given an infusion, epidural bolus of just 0.065% bupivacaine, and the patient developed hypotension. I was smart enough to recognize the hypotension, but then I gave ephedrine 6 milligrams IV bolus. The patient became still hypotensive again, developing this rhythm. So I did not know what this rhythm was. And I actually took the 12 lead ECG and ran to a cardiologist to find out what it was. He said it's a multifocal atrial tachycardia. See, the P wave morphology keeps varying. Every QRS complex will be actually preceded by a P wave, but the P wave morphology will keep changing. Let me go to lead 2. So the P wave morphology will keep changing, as you can see everywhere. So it's a multifocal atrial tachycardia, which I did not know. It is a narrow complex. It is an irregular tachycardia. So you have to cardiovert him with 122 joules to 200 joules. So this case, I did not know. So I did not see that I should not have given a sympathomimetic in a COPD patient who is having a severe, actually he had symptoms of acute COPD exacerbation as well. So in that case, if you give a sympathomimetic which is going to aggravate his symptoms, then they may land up in an atrial arrhythmia. So the treatment of choice would have been a noradrenaline infusion or a phenylephrine bolus followed by a norepinephrine infusion. The key is whenever you give a sympathomimetic or you put a COPD patient to a sympathetic drive, they may actually go from various ranges of atrial arrhythmias, from multifocal atrial tachycardia, atrial flutter to atrial fibrillation. So this has to be kept in mind, and you have to read extensively before you are taking up a case, because we were smart enough to take the case under epidural because we wanted to avoid general anesthesia in that patient. But I did not know this ephedrine can precipitate such a rhythm. So you have to know the patient while you are taking what can precipitate an arrhythmia and what has led to an arrhythmia to improve the perioperative care. Always in anesthesia, it is about calling for help. Whenever you are confused, whether it is a VT or SVT with aberrancy, you actually treat. If it is hemodynamically stable, you give adenosine 6 milligram. If the rhythm is reverting, it must have been an SVT. If the rhythm is still not reverting, then it must have been a VT. Then you actually treat with amiodarone. If the pulse is stable. If they are unstable, you are going to cardiovert, and that there it is going to end the problem. But then, even then, if it is not reverting, you can actually call a cardiologist or a fellow anesthesiologist to call for help in the perioperative period. Thank you.
Thank you, Dr. Guru Sandhya. It was indeed a very excellent presentation. Very basic for every PGs to get understood. And we have a couple of doubts. One doubt is, I see junctional and atrial ectopic more commonly in spinal anesthesia in a previously normal person. Is there any specific cause for it?
No, usually atrial ectopics are not that symptomatic as well. They can be physiological or concerning, then we can treat. If not, we can let it alone and it will resolve on its own. Junctional rhythm, we can always treat with atropine if it's hemodynamically concerned.
Okay, thank you. The next doubt is, before cardioversion for AF, should we rule out any thrombus in echo?
Yeah, if the patient has got acute AF, say less than 48 hours, and if the patient was known to have an AF before, only developing in the perioperative period, then we can cardiovert. If the AF is more than 48 hours duration, or if the patient is known case of AF, then we can only aim for rate control or not rhythm control. You need not, like, we aim for rhythm control only when we cardiovert, we are aiming for rhythm control. We need not aim for rhythm control in a chronic AF or a persistent AF which has developed into a AF with fast ventricular rhythm. What we aim for in the perioperative period is only rate control, which can be achieved by a beta blocker or a calcium channel blocker. You need not, we have to look for, even if the cardiologist is going to attempt for a cardioversion, they will put the patient 3 weeks on anticoagulation and then only cardiovert for a rate control, never in the perioperative setting. You have to determine whether you are aiming for rate control or rhythm control. If it is acute, yes, we can attempt for rhythm control, provided the heart is structurally normal, or before we would have seen if the patient is previously a cardiac patient and echo. But if the echo doesn't have an LA thrombus and if the AF is less than 48 hours, then you can cardiovert. If it is more than 48 hours, it is dangerous. We need not do it. We can aim only for rate control with beta blockers, calcium channel blockers, digoxin, if the patient has got an MS or so.
Okay, thank you very much, and that's a very important point.
Thank you.
Now we can move on to the next topic, and I invite Dr. Ranjan sir to speak upon how to manage patients on pacemakers. Dr. Ranjan sir is a professor and HOD of PIMS Pondicherry. He's a former ISA president, Puducherry. He has conducted various TE workshops and airway workshops in South Zone and ISA conferences, and his areas of interest are cardiothoracic anesthesia and regional anesthesia. He has published over many original papers, 15 original papers, and also case reports. Over to you, sir.
Good morning, ma'am. Am I audible? Is my slides visible?
Yes, sir. You're audible, sir.
Thank you. Thank you so much for the introduction, madam. First and foremost, I should congratulate and thank Edward, sir, for starting this academic activity. I really appreciate your effort and patience in teaching postgraduate students as well as consultants, and kudos to your team, sir. So today, I'll be discussing about anesthesia for patient with pacemaker. Okay. Yeah. Let's start with the case scenario. This is a 65-year-old gentleman who met with an accident. He has a left humerus fracture, left side humerus fracture, and he's posted for plating and plating of the humerus. History-wise, he also shows that he says that he has a cardiac implantable electronic device inserted 1 year back, and he is asymptomatic now as per the cardiac complaints are contained, and this X-ray shows this feature. Can anybody tell us what exactly, which type of cardiac implantable electronic device is this? By the X-ray, can we make out what it is? You can type it in a chat. We will take that at the end of the session. So he has this and he doesn't have any symptoms now. He's a known coronary artery disease patient. His ejection fraction is around 40%, moderate LV dysfunction. He's a diabetic and hypertensive. Now he is posted for elective procedure. How are we going to manage these patients? So how do we manage? This article will tell you almost 100% how to manage a patient who has got a cardiac implantable electronic devices. It is an ASA task force recommendation to manage these patients. My talk is mainly taken from this article as well as some of the British journal as well as Indian journal articles. So let's see what is CID. Cardiac implantable electronic devices. There are two types mainly. One is a permanent pacemaker. Another one is automated implantable cardioverter defibrillator. Now a new one which is added, which is known as CRTD device, nothing but a cardiac resynchronization device. What exactly is these things? Let's see. Pacemaker, permanent pacemaker, it has mainly two things. One, pulse generator. It houses the battery, a small computer which generate electric potentials or action potential or a pulse potential which are carried through these leads. Depending upon the type of lead, the permanent pacemakers are divided into three types. A single chamber pacemaker where the lead either is in the right atrium or in the right ventricle. A dual chamber is where you have a lead both in the right atrium as well as the right ventricle. The third one, the newer one, is a biventricular pacemaker which has got lead in the right atrium, one lead in the right atrium, one lead in the right ventricle, the third lead in the coronary sinus and activates the myocardium of the left ventricle. So this is basically known as CRTD devices, chronic synchronization devices, right? So that is pacemaker. What is AICD? AICD is 2.0 of permanent pacemaker. The extra added feature, apart from the permanent pacemaking, it has an extra added feature to treat ventricular tachyarrhythmia by overdrive pacing or to treat defibrillation by giving a shock. So this is helpful in those patients who suffer from sudden cardiac death or repeated cardiac defibrillations, cardiac ventricular fibrillation. The third one is cardiac resynchronization therapy devices. Okay, this is a modified one, 3.0 of the permanent pacemaker. It's a permanent pacemaker facility, plus it activates LV and RV together. There is a synchrony between the RV and LV. A normal patient can tolerate by atrial and ventricular leads. RVs activates, and LV activates little later compared to RV in a normal permanent pacemaker. This can be tolerated well by good LV patients, but if the patient has in a failure patient, a NYHA class 3 or 4, his ejection fraction is less than 35%, they will not tolerate this type of dyssynchrony. This is called as pacemaker syndrome. So whoever is having a pacemaker syndrome, probably they need the third lead, that is coronary sinus activating the LV, which is known as CRTD devices, right? So this is how the CRTD device, where through the coronary sinus, the third lead activates the left ventricular myocardium, and then RV and LV beats in synchrony, prevents any failure symptoms or pacemaker symptoms. Indication simple: permanent pacemaker is basically problem with any conduction system. If the patient has, apart from this, he has a life-threatening tachyarrhythmias or repeated ventricular fibrillation, then AICD is the treatment of choice. And if the patient has a heart failure, ejection fraction is less than 35%, NYHA class 3 and 4, severe LV dysfunction, then CRT is the treatment of choice. Permanent pacemaker indication, there are plenty. If you go into the journals, there are boxes of indications, but in general, it is classified as class 1 and class 2 indications, where class 1 is symptomatic sinus node dysfunction, symptom in the form of syncope along with bradycardia, or third degree complete heart block, or type 2 second degree AV block, regardless of the symptoms, and permanent atrial fibrillation with symptomatic bradycardia is a class 1. Definitely it will benefit. Class 2, symptomatic chronotropic incompetence, symptomatic type 1 as well as type 2 second degree heart blocks, and syncope of unknown etiology, and by investigation it has found out that there is a sinus node dysfunction. They are the candidates for permanent pacemaker. Nomenclature, probably everybody knows about this nomenclature, a bit confusing one, but it is important whenever we are managing a permanent pacemaker patient coming for surgery. It is it was given by North American Society as well as the British Pacemaker and Electrocardiographic Societies. This is called as NBG grading. It has 5 letters. Okay, each is position 1, 2, 3, 4 and 5. What is important is these 3 positions: first, second and third. Fourth is also important. Fifth is only for CRTD device. First position is pacing. Which chamber is paced? The pulse generator sends the electric potential to which chamber is the first position. It can be atrium alone, ventricle alone, or both atrium and ventricle, which is called as dual. Sensing. Sensing is basically to find out if the patient has his own intrinsic atrial activity or ventricular activity. So if it senses the atrium, it is A. If it senses ventricle alone, it is V. If it senses both atrium and ventricle, it will be dual. You can switch off the sensing also, none. It will be a 0. Response, when you sense the chamber, what is the response? Either it can inhibit the pulse maker to send a pacing potential to this, that is the I, or trigger. You can trigger the pulse maker to send us pacing a potential to either atrium or ventricle. So it can be inhibition, trigger, dual, or none. Now the triggered is of historical importance. We don't use it regularly for most of the pacemakers. Trigger is good if the patient is on in a ventilator. If the patient is on ventilator there is a trigger to trigger the breathing, right? So it will prevent the rate of breathing exercise can be prevented if you have a trigger T there. But heart, it's all or none phenomena. If there is a activity, it will be 100%. If there is no activity, nothing, 0%. There is no 10% heartbeat, 30% heartbeat, or 50% heartbeat. So triggered is almost historical importance. We are not using it. Very rarely VAT is used, that is ventricle is paced after sensing the atrium, which is triggered. Let's take an example of AFib, atrial fibrillation. Patient has atrial activity of 150, whereas ventricle activity is only 30 or 40. In spite of medical treatment, you are not able to manage this ventricular bradycardia. Then atrium is sensed, trigger the ventricle to get a heart rate of around 70 to 80. This is the only indications for T, otherwise we don't use it. Right, the fourth and the fifth I'll come back to you later. So with a lot of permutation combination is possible in this, right? AAI or AA0, VVI, DDD, so many combinations is possible. So in grossly, we can divide the disease into sinus node dysfunction or AV block, and so many diseases can be under these headings. So all this heading, we have different modes, and you can see that all the disease, one common thing is DDD. So DDD is like an amiodarone. When not everything fails, right? Amiodarone, medical management of arrhythmia, amiodarone comes into picture. You can say that amiodarone is the mother of all arrhythmic drugs. Similarly, DDD is a mother of all pacemaker modes. Then why don't we use DDD? So DDD problem is it consumes a lot of energy. Unnecessarily, it will stimulate atrium and ventricle when it is not required. For example, if it is an SA node disease, what you need to do is just to activate the atrium. You need not activate the ventricle, right? So if you put the DDD, unnecessarily it might activate the DDD. So that is why we don't use DDD as a first line of management. Try with other management, then we go back to DDD. Apart from just setting the mode, that is not enough. You need to do all other setting also. Like in a ventilator, you just don't put SIMV and come back, right? You will set inspiration time, expiration time, that is IE ratio. You will set how much pressure support to be given, how much tidal volume to be given. So many things you will set apart from putting the patient on modes. Similarly, when you put the patient on pacemaker, you are apart from putting the patient on modes, you are also supposed to set the rate, minimum rate, maximum rate, duration, that is QRS duration, PVF duration, PR interval, RP interval. So many durations will be there in the pacemaker which needs to be put. How much voltage output, refractory periods, PR interval, all these things should be put. Hysteresis is basically to prevent any dysynchrony between the RV and LV. That also needs to be put in the program. I will not go into the detail of it. I'll give you a few examples about the modes. One of the mode as an anesthesiologist we should know is this asynchronous pacing mode. Whenever we put the patient pacemaker who comes for a surgery and he has got a chance of electromagnetic interference or cautery interference with our pulse maker, we go back to asynchronous pacing mode, either by putting a magnet or by using a reprogramming device. So the moment, these are the asynchronous pacing modes which will be available: AOO, VOO or DOO, depending upon what the patient is on. Okay, they are basically nothing but in a ventilator like a controlled mechanical ventilation. Right? In a controlled mechanical ventilation, you set a rate of 12. Whether patient is taking breath or not, it doesn't matter. It will be giving 12 rates per minute. Right? Similarly, asynchronous pacing. Here, it will not sense any of the patient internal activity. It will not sense any of the cautery. It will not send any of the myopotential activity. It will just give whatever rate you have set. Right? So the one good example is here. I'm giving you VOO. Always pacemaker potentials or spikes will be seen in the ECG. Right? So this is one simple example. We have put the patient on VOO. You can see this is the pacing spike which which activates the ventricle and produces QRS wave. This is patient's native, his own QRS activity. You can see at a fixed rate, our pacemaker is activating the ventricle. It doesn't take into consideration whether patient has got his own activity or whether he has got an ectopic bit. So it will keep on giving the ventricular rates. The only problem is like this R-on-T phenomena. Dr. Guru Sandhya spoke about R-on-T phenomena which can initiate ventricular tachycardias and fibrillation. We should be careful. So this is the drawback of this VOO or AOO. Right? So the other which one we should be aware of is AAI. As I told you, first letter is the chamber which is spaced, second is the chamber which is sensed, and after sensing, what is the response is the third letter. Here the atrium is spaced, atrium is sensed, and if there is an atrial activity, it inhibits the pacemaker to send any electrical activity to the chamber to be paced. Right? So this is the most common one which is used for sinus node dysfunction. When AV conduction is intact, we use AAI mode. I'll give you an example. Here you can see it is in AAI. Okay, here atrium is spaced. After you will set PP duration. That value will be added to your pacemaker. If the time interval is prolonged, that will be sensed and there is no activity. So the pacemaker will send an electrical impulse to the atrium and there will be a pacing response. Next, within a particular time, there is a native activity, right? So there is a native activity. So A is sensed. What will do? It will inhibit the pacemaker to send any electrical impulse so that the patient's native activity will be continued. The other one is VVI. Whenever you have a AV nodal dysfunction, we put the patient on VVI or DDD. So this is what it is. The same way, ventricle is phased, ventricle is sensed. Response, if there is a ventricular activity, it inhibits the pacemaker to send any electrical potential or myocardial potential into LV, RV, any ventricle. So here you can see there is no electrical activity. It is sensed, so it allows the pacemaker to send. The next one, again, there is no electrical activity, so it is sensed and that allows the pacemaker to send the electrical activity. Here you can see the patient has got a native ventricular activity that is sensed, so that inhibits the pacemaker to send any electrical activity so that the native activity is continued. Again, the same pacemaker is doing it, right? So the most commonly used one when we don't have any option is the DDD. Okay, so this is the most commonly used whenever a patient has got a complete heart block or myocardial infarctions, and DDD is used. DDD helps in synchrony between the atrium and the ventricle. Okay, there are 4 different rhythm can be obtained with the DDD. That is, I will show with an example. Okay, so the first one. Here is a good example of DDD. Here you can see atrial activity is there. So atrial activity is sensed. It will not send electrical potential to the atrium. But after a certain PR interval, there is no ventricular activity that is sensed. So it will send an impulse to the pulse generator, but will send an electrical potential to the RV. So there will be spike. So this is A sensed, B paced. The next one, here you can see both atrial and ventricular activity is not there, which is sensed. So both atrial activity and the ventricular activity is by the pulse generator. So A is paced, B is paced. The third one, here there was no atrial activity, so A is paced, but it senses the ventricle. There is a native ventricular activity, so it inhibits the pulsemaker. So this is A paced, B sensed. The last one, both atrium and ventricle are native activities there. Both are sensed, A sensed, B sensed. So no electrical activity from the pulse generator. Native activity of the atrium and ventricle is continued. So these are the 4 things which can be obtained from DDD. Fourth letter is the rate modulation. So rate modulation, how I explain? It is like your smart watch. Nowadays, everybody is using the smartwatch, right? You use a smartwatch, it will tell you what is your exercise strength, whether you are running or whether you are taking rest. When you run, how much is your heart rate, how much is the energy consumption. All these smart watches will detect. The same thing is adopted in your pacemaker generator, where it finds out. Permanent pacemaker, the first 3 modes are like a robo. Whatever you are sensed, whatever you are given, the feeder, that will only go into it. It doesn't have any sensory, any emotion. This fourth rate modulation, when you add, it finds out what the patient is doing, whether there is an activity. With the activity, you need to have an increase in heart rate. So that is added into the fourth letter, the rate modulation. It is good when the patient is not coming for surgery, but when the surgery, this letter needs to be switched off. Unnecessarily, it can sense the cautery activity, it can sense the myopotential activity, it can sense the shivering and unnecessarily alter the pacemaker potentials. So fourth letter, irrespective of what the patient is, what procedure he is coming, should be switched off when he comes for surgery. Fifth letter is a multi-site pacing. It is only for CRTD device where the patient has got both RV and LV, right? So that if it is there, that number is added to the 5th position, which very rarely concerns to us during the surgery. Now coming to the perioperative management, why are we so much worried about the pacemaker? This is 2016 data, Indian data, which says that around 37,000 cardiac device implantation took place during that year in 2016. Imagine, we are 6 years after this, probably the number would have gone 6 times. Around 2.5 to 3 lakhs patients will be receiving 37,000. Around 3 lakh patients will be receiving CID devices. out of which 80% are permanent pacemaker, 15 are ICDs, and 5% are CRTDs. Now, all these patients will start coming to your OT with some other non-cardiac surgery. You should be ready, right? So, pre-op evaluation, of course, you need to know about the pacemaker, but more than the pacemaker, you should know why this pacemaker is inserted to this patient. There must be some problem. Okay, it may be a post-MI, or it may be HOCM, or it may be congenital heart disease, or so many things. So all these things to be assessed. His associated disease like hypertension, diabetes, severity, current functional status, medication. Basically, you should follow ACC AHA guidelines for a cardiac patient coming for a non-cardiac surgery in pre-op evaluation apart from your pacemaker. In pacemaker, how do you do? Device evaluation, establishing whether the patient has got any device, defining the type of device, and determining whether this patient is dependent on this device. How do you establish whether the patient has a device? It is a very, very meticulous one. Whenever you insert a device, you will get a notebook, you will get a sticker, which always will be attached to patient case sheet or medical records, which will say that what type of device has been inserted. Even otherwise, with the chest X-ray, you can identify what type of device patient is having. ECG should be taken to find out whether the patient is dependent on pacemaker or not. Right? So, how do you know that with the chest X-ray, what type of patient, what type of device patient is having? See here, we have three types of devices here. This is a single chamber, ventricular pacing, okay, single chamber, permanent pacemaker. Here, two chamber, permanent pacemaker, one in the atrium, one in the ventricle. Here, three chamber, one in the atrium, one in the right ventricle, another through the coronary sinus into the left ventricular. So, biventricular spacing, two chamber pacing, single chamber pacing. So, X-ray is good. The third one, AICD. This is what AICD looks normally. Okay, this is how the AICD looks under the X-ray. You'll have two shock coils. One, it will be in the superior vena cava, one will be in the right ventricle. So these shock coils will be visible in the chest X-ray. So this you can see. In this X-ray, you can see the shock coils, one in the superior vena cava, one in the right ventricle. So shock coils, whether it is a CRT device or a permanent pacemaker device, shock coils will be very easily seen in the X-ray. It is important to know what type of device. I'll tell you later. Defining the type of device. One, through the X-ray, you know, if the patient has a record, it will have an idea whether it's a PPM or a AICD or a CRTD device, or otherwise in chest X-ray. Even in the chest X-ray, good X-ray, digital X-ray will tell you the manufacturer company logo, as well as there will be a unique number, like an Aadhaar card number, it will be there in that, which is unique to it. And you can, once the company logo is found out, you can call the company and give the number. They will give you the details of the patient. Detailed device interrogation can be done even patient from far away from the patient area. Third and the important one, to determine whether the patient is heart rate device dependent. So there are three things we should know. Why this pacemaker was put. If the patient had a symptomatic bradyarrhythmia, that is syncope associated with bradyarrhythmia, that indicates patient is a pacemaker dependent. Or if you had a successful AV node ablation, once it is done, this is a permanent. AV node ablation is done, then he is dependent on CIED. The third, when you take an X-ray, and if you see that more than 80% of the electrical activity is from the pacemaker, that means he is dependent on pacemaker. This is very, very important to understand. Remember this point. Device interrogation. How do we do the device interrogation? As the Heart Rate Rhythm Society recommends, if it is a permanent pacemaker, every 12 months you need to do the device interrogation. If it is AICD 6 months, CRT 3 to 6 months. How do you do? It is a big one. Instrument is a big one. The mouse pad is put over the patient's scar or where the permanent pacemaker is situated. And that will assess the device interrogation will be done. Is my slides moving, madam? I just wanted to know. Cheryl, madam, is it?
Yes, sir. Your slides are ready, sir.
Yeah. Okay. Thank you. So this is the. So this is the machine which will interrogate. Device interrogation. You put the patient. It will take 5 to 10 minutes. So it will tell you about the remaining battery activity. In this, it is 13 years. Usually, Indian Metronics will run for 7 years. And it also gives you what is the P wave potential, what is the R wave potential, what are the pacing, durations which you have kept, what is the mode, what was the lower heart rate, higher heart rate. Also, you can change the modes. It is a DDD mode. We are changing into VVI mode. Once you put the patient on VVI mode and convert into whatever mode here into asynchronous mode or whatever mode you. So the only problem is it takes around 15 to 20 minutes to do this device interrogation and changing, and you need an expert to do all these things, right? So that's the only thing. But all these patients, if it is more than 1 year or 6 months of AICD placement, you need to interrogate these devices. Now, preoperative preparation, the main thing which is concerned for us is whether there is an EMI interference, electromagnetic interference. Okay, if there is there, do we need to reprogram this CID pacemaking into asynchronous pacing mode? And if there is an AICD, or suspend all antitachyarrhythmia functions. When you're doing this, you should make sure that temporary pacing and defibrillator equipment should be always available. Don't depend entirely on the permanent pacemaker if you do asynchronous mode. And also possibly be aware about the possible effect of anesthetic techniques on the CID. So EMI, what is EMI? It's an electromagnetic interference which can disrupt the operative electronic device when it is in the vicinity of electromagnetic field. Why are we worried? Because it can inhibit the pacing due to ventricular oversensing. The cautery as sensed as a R wave, okay, or P wave, and that will be sent to pulse maker. So it will prevent sending any pulsing, potential pulse maker activity, and patient can go into severe bradycardia or severe tachycardia. This signal can be noted as R wave, and that if it is heart rate is 180, 200. This electrical potential is sensed as R wave, and it can give shock or it prevents sending any electrical impulse. So the EMI is a dangerous thing to happen intraoperatively for all the pacemakers. So what are the factors which causes EMI? The most one is the electrocautery, monopolar more than the bipolar, evo potential monitors, nerve stimulators. Okay, we will come to that. Fasciculations caused by scolins can cause an EMI. Shivering, large tidal volume. If your fourth letter, that rate modulation is on, then the large tidal volumes can cause a problem with the pacing. It acts as an EMI. External defibrillator, MRI, radiofrequency ablation, ESWL, ECT, all this can cause EMI. Okay, so how can we prevent? The simple is, if the EMI and CID interaction decreases as the distance increases. If it is more than 15 centimeter or if it is more than 6 inch, the chances of EMI is very less. Monopolar causes more likely. Okay, coagulation mode causes more EMI compared to the cutting. Okay. Cautery tool and current return pads, if they are positioned very near to each other, then EMI is very, very less. Using short, intermittent, irregular burst at the lowest feasible one prevents EMI. So this is what I'm saying. If the cautery pad is near to your cautery, then the electric current runs from the cautery to the pad in this direction. Imagine this pad is kept somewhere in the shoulder or in the scapula. When the current passes through all the way from the inguinal area towards the pass, probably affecting your pacemaker. So always, if you're using a monopolar cautery, always use the pad very near to it. Mechanical interference, apart from EMI, even mechanical interference can cause, that is your CVP guide wire, it can mechanically dislodge the lead or itself can stimulate the atrium and ventricle, which is dangerous to the patient. Atrial oversensing because of your guide wire, that can also inappropriately increase the ventricular pacemaker. Even bone saws, whenever the orthopedics procedure, whether they are doing a THR, DKR or humerus plating, this bone saw can also cause a problem, mechanical interference. So reprogramming, I already, how do we prevent this? Is by doing two way. One, with a programming device, reprogramming device, which I showed you, interrogating device, that itself converts the magnet, which is very simple one and easy, which converts any mode into asynchronous mode. Reprogramming with a programming device, it should be done by trained personnel. You need a big equipment. It will turn both permanent pacemaker as well as AICD into asynchronous mode. So this is the advantage. AICD, it has two functions. One, anti-tachyarrhythmia, another pacing. only the reprogramming device converts AICD into asynchronous. Magnet will not convert AICD into asynchronous mode. It will convert only AICD into anti-tachyarrhythmia disruption. Okay. So with the magnet, it produces asynchronous pacing, AAO, DOO, or VVO. It suspends only the anti-tachyarrhythmia function of AICD, not the permanent pacemaker function in the AICD. Right? So basically, it converts into asynchronous mode. This patient, he has got this is a pacemaker syndrome. Sorry. Okay.
There is a disturbance in the audio, sir. Ranjan, sir, there is a disturbance in the audio.
Sir?
There is a disturbance in the audio. So you can switch off your video and
Okay, sir. Okay. Yes, sir. Yes. 1 minute. Okay.
yes, sir.
So is it better now?
Better now.
Yeah.
So you proceed, sir.
Yeah. So here you can see the patient is got a high risk, high mode. Now this always you keep the magnet and just simple pacing the magnet over the scar, or it is gone into asynchronous mode of 60 to 80, whatever you have set it. Right, it is 80 beats per minute. At the moment you remove the magnet, it will go back to its original position. It takes hardly 1 or 2 seconds to convert. Okay. So when do you need to do reprogramming? If unwanted patient movement from an ICD shock, even if there is no EMI, if if the surgeon is doing an intraocular operation or a neurosurgery, where precision is important, patient movement should be prevented. Even though if there is no EMI, it should be reprogrammed, right? Okay. Intraoperative management, all ASA monitor, the same ACC AHA guidelines should be used. So whenever you are using a ECG, you should be very careful. EC monitor should be put to diagnostic mode rather than the monitor mode, because diagnostic mode gives wider frequency responses. Pulse maker potentials can be seen easily. So here you can see this patient is on a temporary pacemaker, but similarly, so you can see this patient was put on a 90 atrial AAI. Okay, you can clearly see the pacing potentials here, the atrial activity. So that is because the patient was in a diagnostic mode. I hope you are able to see the video and as well as see this is the diagnostic mode and this is the monitor mode. So if you put the patient on monitor mode, see, you are not able to see any pacing spikes. It looks like as if patient has got his own native heart rate. Okay, so always put the patient on diagnostic mode where you can see clear pacing spikes and you know that your pacemaker is working properly. So this is very important whenever the patient is on monitoring on the ECG, right? Always keep transcutaneous pacing or defibrillator pad next to the patient throughout the procedure. So what happens is this is the monitor which has both the transcutaneous pacing facility as well as defibrillation facility. It usually comes with the disposable pads which any patient who is on a permanent pacemaker should be applied. Okay, normally what we do, we put one on the left side and one on the apex. All right. So by this the electric current passes like this, it can inhibit your permanent pacemaker. So when the patient is on permanent pacemaker, always put anterior-posterior so that current passes anterior-posteriorly, preventing any disruption. So you have in this defibrillator, you have a mode, pacemaker mode as well as cardioverter mode or a defibrillator mode. You put it in a pacemaker mode, it will go into asynchronous mode, AAO or VEO, DOO, whatever it is, and it will give you the transcutaneous pacing. When your PPM is not working, it is disrupted or it has some problem, then you can go back to the transcutaneous. Also, if the patient is on EICD, you have converted into disrupted the anti-tachycardia, then you can do cardioversion as well as defibrillation depending upon the patient condition with these transcutaneous pads. So that is the important of it. Anesthetic agents, there is no particular effect of anesthetic agent on the CIED, but high doses of fentanyl or dexmedetomidine should be avoided since it can cause tachycardia. As Dr. Guru Sandhya was talking about long QT syndromes, so you should always be careful. Avoid these drugs, methadone, haloperidol, ondansetron, and high doses of inhalation agents. All these things can affect the long QT syndrome and cause problem to the patients. Whatever it is, you should consider that these patients are cardiac patients coming for non-cardiac surgery. So you should follow all the ACC/AH guidelines and avoid all these factors which can cause malignant arrhythmia. Even the patient is on pacemaker, hyperkalemia, hypokalemia, hypoxemia, factors which can cause MI or catecholamine stretch. All these things should be avoided. Right? So, succinylcholine, succinylcholine causes fasciculation, which can cause EMI. So, but it is transient. Usually, it will not affect the pacemaker. Lot of studies, case reports have been shown that it will not affect the pacemaker. So, if it needs to be used, it can be used. Even for ECT, scoline can be used. The effect will be very minimal. Hemodynamic management. Remember always, they are on pacemaker, they will not respond to hypovolemia. There won't be any tachycardic response to hypovolemia. Be very ready with this. So you have to be very careful with the fluid replacement. Avoid indirectly acting drugs. In the event of arrhythmia or bradycardia, immediately the magnet is applied, remove it and get the anti-tachyarrhythmia function ready. Failure of the rhythm to revert, then use the external defibrillator or cardioversion to get the revert. Emergency surgery, you don't have a time to evaluate. Patients who are undergoing supraumbilical surgeries are at very high risk. So you always be ready with the magnet, whatever it is, and transcutaneous pacing and defibrillator should be ready. Post-op management, the main function during the post-op is interrogating and restoring the CID functions. Rate and rhythm should be monitored. Keep the transcutaneous pacing defibrillator till patient is shifted from the recovery room to the ward. Right? Specific conditions, MRI. Most of the devices in India are not MRI safe. MRI is not advised for pacemaker. Nowadays, in the Western countries, the new devices, MRI safe devices have started coming. Till that comes to India, MRI is contraindicated in case of pacemakers. Lithotripsy and RF ablation radiation therapy, as long as the beam is away from the pacemaker, it can be safely be done. If the beam is very near to the, not in the lithotripsy, in RF radiation therapy, if the beam is near to the pacemaker, then probably you need to put the patient on asynchronous mode. ECT, again, lot of studies, case reports are there which says that ECT will not affect, even if it affects, it will be transient. So ECT plus scoline can be safely be done. Peripheral nerve stimulators and pacemaker. There is one report in 2008. It's a meta-analysis. They did a lot of studies were analyzed, and it shows that PNS, which uses 2 milliamperes of current, will not affect. Even if it is a supraclavicular block, you are using a PNS to identify the brachial plexus. It will not hinder, it will not affect the permanent pacemaker. So PNS, peripheral nerve stimulator, can be safely used even if the patient is on pacemaker, need not put them on asynchronous mode. So this was the case scenario, right? We had a humerus fracture, patient had a AICD very next. So the distance is very less than 6 inch. Obviously, they're going to use a bone, drill, as well as they're going to use cautery. So there will be an EMI. Okay, so what we are supposed to do? So if you are watching it in a mobile, probably you won't be able to see this. I'm really sorry. Let's say this patient, you can see he has got a 2 high radio things. That means patient is on AICD, not simple pacemaker, right? So he is on ICD. Will there be an EMI? Of course, yes, because very near to the ICD. You need to deactivate the ICD. Either using a programmer or a magnet, right? Is the patient pacemaker dependent? What are the factors which will tell you the pacemaker dependent? If he has all the activities by the pacemaker, he is a symptomatic bradycardia. If AV nodal ablation has been done, yes. Then if the distance is less than 15 centimeter, of course, yes. Then you need to reprogram with the reprogrammer, not with the magnet. ICD, If you reprogram with the magnet, it will only abolish anti-tachycardia, not the PPM. So both to get an asynchronous mode plus AICD abolishment, you need a reprogrammer. If the distance is high, then only magnet will be ready is enough, right? If the distance is very high and there is no EMI, magnet can be just kept there. So to summarize, be ready to face more CIDs, have a multidisciplinary team, anesthesia cardiologist, educate the surgeon about the EMI and the effect of EMI on the CID. Always keep magnet as well as transcutaneous pacemaker ready. Always follow ACCH guidelines. Remember, these are the cardiac patients who are coming for non-cardiac surgery. Avoid factors which can trigger tachycardia and arrhythmia. Keep a close watch on EMI and ACU interactions. Thank you so much.
Thank you, sir, for your wonderful presentation. Sandri madam, there is no questions in the chat box, I think. Sandri madam?
Sir, no doubt, sir, in the chat box.
Okay, today both topics were very tough topics, but it was very well and explained by the two speakers, that is Ranjan and Guru Sandhya. They have made this topic very easy to understand for the postgraduates. So with that, we come to the end of this program. I thank Ranjan sir and Guru Sandhya for their excellent presentation. The next week, the program will be 2 hours. Interesting ASCII based questions will be explained in the next meeting. So don't miss it. Thank you, one and all. So,
thank you, sir.
Thank you, sir. Shilpa, we can finish. With that, we can wind up this session. Thank you, one and all.
Thank you.